you invited me to come and sit up here. At the last instance, I'm not on the program, but that's fine. Make some notes myself because in this case. You have like some pen or something to write? Yes.
Yes, I asked them 2 days ago to give me a summary of the cases, just to have a quick look at them. So kind of last night, went quickly through them. A couple of them sound like chronic migraine and lots of medication abuse.
I will present myself again. I'm Dr. Randa Amin, lecturer in Ain Shams University, Neurology Department. First of all, I would like to thank all the survivors to the end who stand with us till this clinical workshop. And the aim of this workshop actually is to present some difficult cases, many of which we face in our daily practice, that have either problem in the diagnosis or treatment, and we will need the opinion of the experts presenting with us, and also our colleagues. I'll present my colleague, Dr. Abdurrahman. He will present the first case.
Hi. I'm Abdurrahman Atif, Assistant Lecturer of Ain Shams of Neurology, Ain Shams University. It's my pleasure to be with you. Thanks for Dr. Rams and Dr. Randa for their continuous support. May I represent this case to share your opinion about diagnosis and treatment. Our first case, Mr. MJ, 68 years old, married male with 3 offspring, working as a businessman with no special habits of medical importance. Irrelevant family history, past history of bronchial asthma on Montelukast and beta-mesosone on demand, hypertension on valsartan hydrochlorothiazide combination, 160/25. Patient underwent lumbar discectomy 15 years ago. His headache history started since 2006 at the age of 56. The pain started left retroorbital and temporal, throbbing in character, strictly unilateral, lasting up to 8 to 10 hours at frequency of 3 times per month. Current frequency is 4 to 6 times per month. Its severity 8 to 9 on visual analog scale. No seasonal variation, more at night, nocturnal, awakening patient from sleep, associated with photophobia, phonophobia, nausea, and vomiting. Redness of eye and lacrimation. Recently, since 1 month ago, pain radiated to the right retroorbital area and became bilateral with maximum intensity over the left retroorbital. Patient sought medical advice with multiple medical trials. The current headache frequency, as we said before, 4 to 6 times per month, and the head score 67. As the medical management the patient received from the start of the his illness, from the start of the headache at 2006, for acute attack, the patient diclofenac sodium injection, partially responsive at the start, currently with no response. Sumatriptan at dose of 100 milligram, no response. Ergotamine, also no response. High flow oxygen, no response. Indomethacin injection, giving a good response. Prophylactic patient received verapamil at dosage of 480 milligram with no response. Topiramate at dose of 100 milligram per day. With current treatment, partial response as regard decreasing the frequency. Prednisolone, patient currently in prednisolone at dose of 10 milligram per day. Current treatment, partial response. Non-pharmacological patient mentioned he had radio frequency ablation before, but he can't mention the type of the ablation, and we can't recall it. Patient received a greater occipital nerve block multiple times last 3 months ago with good response at decrease of frequency and intensity. As we mentioned before, current hit score is 67. Our debate about the diagnosis and the medical treatment. Thank you.
So your working hypothesis is has been cluster headache?
Yes, we diagnosed it as a cluster headache at the start, but it is not. Don't have seasonal variation, and its duration is above 3 hours. And the other thing, it is started after 50 years old.
Yes.
The age of onset is slightly atypical.
So what made you think of the cluster headache diagnosis? What was the thing that made you think of the cluster headache diagnosis?
What we think of, was strictly unilateral, severe pain. The intensity was severe. Visual analog scale, it was about 8 to 9. With autonomic, with nocturnal, it was nocturnal. It is also in the migraine, but one of the features of cluster headache, it became nocturnal. That was we thought about cluster headache at the first, but radiation to the other side and the response for high flow oxygen and verapamil wasn't that much better. So we thought about other possibilities.
So if I may comment first, and I'll hand over to the other chairpersons. But to me, this headache condition is fulfilling the migraine criteria. Even in migraine, there is a percentage, perhaps 10% of patients that have strictly unilateral headache attacks. As you know from the criteria, headaches untreated last anywhere between 4 hours and 3 days. So the 8 to 10 hours is fine. And again, the cranial autonomic symptoms, well, in the past it was seen as something very specific for the TACs, cluster headache and so on. But it's clear now that many migraine patients have autonomic symptoms.
Yes.
In fact, in my country, I'm from Belgium, we have a French part of the country. They even have a word for it. They call it la migraine rouge. It's like the red migraine. So it's known to people that sometimes redness of the eye can occur. So to me, it fulfills the migraine criteria. Some comment also on the absence of effect of oxygen or verapamil. Of course, none of those drugs can also be considered a diagnostic test for any condition. There's been a good effect on indomethacin. You might also consider this, would this be an indomethacin responsive headache? But on the other hand, indomethacin is used as acute migraine treatment, like other NSAIDs. So to me, it sounds like this fulfills migraine criteria, but I'll just hand over to you.
Thank you, Koen. I agree that it's more likely to be a migraine rather than cluster headache. And just a few things really in the history. So we're talking a patient who claims that his headache started at the age of 56. Are we talking about this type of headache or ever headache in his life. It will be a bit surprising for someone to say that he never ever had a headache. And I think this is a problem that happens across cultures. Even in the UK, I get a patient who comes to see me in the clinic, and you ask him, so when did you start to have headaches? And they say, well, it's happened last year. And then you kind of really need to drill it down in the patient. The patient comes to the clinic really concerned about this headache that's been giving him a grief for the last few years. But actually, when you need to establish a diagnosis, it's very important just to go back to the background. And I always kind of tell them, look, I know you're coming to me with this pain, but I just want to get some background checks first. So I tend to discuss, forget this headache for the time being. Let's just talk about your teenage years or your childhood. And more or less, most people end up having, oh yeah, I used to get that normal headache. And when you drill it down, it turns to be a migraine. Another feature probably I would be interested to know whether his headache or those headaches are worse on physical activity, because that's very important. Or whether he gets any restlessness or agitation. That's kind of another thing, kind of give you a hint where things are going to go. You mentioned that, for example, I agree with Koen again about sumatriptan and oxygen not being used as a diagnostic way of telling that this headache is going to be this way or that way.
In addition to what you said, I consider, he's like 58, starts, probably this is new headache started. It's not continuing headache from the early childhood. And strictly unilateral with autonomic features, I would give indomethacin full dose first for a few days to see the response. Probably also, you did not mention sphenopalatine ganglionic, blockade with the, SPG blockade. If I get any response or, important response, then I will stick to the, my point will be a little bit changed. But if we do not get any response, then we have to treat this as a migraine. Yeah. But in that case, as you said, it looks to be chronic headache, or if you are thinking it's a chronic cluster, the response will be different for verapamil. Yes. And I think the other issue is we need to consider the confounding factors for, 10 years old headaches, how about the sleep problems, depression, anxiety. These are also, or any malnutrition or vitamin deficiencies. These are all confounding factors that patient has to be, checked carefully.
Okay, we check for this.
Okay. I agree that the age of onset is not the most typical, and as you say, I fully agree. In some patients, you have to go back to childhood. Even people may also have some recall bias. It's not. Also for cluster headache, the majority of patients at onset are between 20 and 50. So for migraine, again, it's not impossible for it to start at the age of 56. And just one more comment. The patient also has arterial hypertension, yeah. And it's only partially treated. It's 16/10. Those are, in my mind, not values that will, give headache of any kind. But they are considered a contraindication for triptan use. I don't know how strict you obey to the rule, but triptans are supposedly only used in patients with controlled hypertension, not with uncontrolled hypertension. So that's something to be careful with as well. Okay.
Okay, regarding the diagnosis now shifted to chronic migraine with medication overuse?
I missed a bit. So the last month, the headaches have shifted into, was that a daily pattern?
Yeah.
And also became a bilateral headache?
Yeah.
Personally, I would think that to me would be rather more of a red flag at this age.
Yeah.
That there's a change in headache pattern, which is not really explained. Medication overuse headache, according to the IHS criteria, you make the diagnosis after 3 months. Of course, this is not a religious time period, but you know, it's something that takes time to develop. And so to me, in my practice, this shift in pattern that is not really explained at this age of 68 would be a red flag
Secondary headache.
to investigate.
Okay.
Yes.
Regarding the response to the treatment all over his history, no good response even.
Yeah, but we have, that again is not necessarily putting me off the diagnosis. I think many of us who see refractory patients are confronted with patients who do not respond to first-line treatments. As a general comment, because of that, there's been a few studies on the use of combined treatment of triptan and a non-steroidal in migraine, because there are patients who do not respond good enough to each of those classes. So that again is not really a problem to me. The problem is the shift in the headache pattern at this age of 68, which is not really explained. And I agree with the other colleague that you have to look for risk factors for chronification and so on.
Okay.
But it seems to be happening quite abrupt.
Excuse me?
It seemed to be happening quite abrupt, quite fast.
Yeah.
And there's a pattern of episodic headaches, and then up we're
shifted.
Yes. So I mean, it's hard to make a definite comment here. I would consider that a red flag. You may use this acronym SNOOP4. Are you familiar with that? It's an acronym that we use for red flags. So patients with systemic symptoms and onset. And also change in pattern. The P is for pattern change. So that to me is a red flag.
Okay. Anyone needs to ask any question about the case or any more opinions? Excuse me? Protocol of temporal arthritis and the MRI are done, and MRA, nothing, improved anything.
I really don't think this is a cluster. It looks more like a migrainous or migrainous related to some other entity at this age with all this localization and both sides and the difference. And it haven't responded to any medication that usually clusters respond to. Did not respond to high dose of verapamil, did not respond to 3 occipital blocks, it did not respond to 100
already
milligram.
take also topiramate, high doses, no response.
Prednisone 10 milligram daily,
200?
100
100.
100.
Okay.
So,
thank you.
thank you.
Any questions? Okay, the second case will be presented with, by my colleague, Dr. Mohammed Assam.
Good evening, dear professors and colleagues. I'm very pleased to be here, and I'm very grateful to Dr. Ramz Rida, Dr. Randa Amin, Dr. Shireen Farag, Dr. Shahnaz, and Dr. Tamer Amara for the opportunity to present to you 2 cases of headache. Personal history, Mrs. FN, 42 years old female patient, married with 4 offsprings, housewife, lives in Cairo, tobacco smoker, 5 cigarettes per day, menstrual and contraceptive history, regular menses, not on contraception, family history irrelevant, past history irrelevant, headache history, the condition started 13 years ago by attacks of headache of migraine features. It was strictly unilateral, throbbing, lasting more than 4 hours, associated with nausea and sometimes vomiting, and it was increased by activity and it was disabling. The attacks were moderate in intensity with a frequency of 3 to 4 attacks per month, lasting for about 2 to 3 days, and it was aborted with excessive use of non-steroidal anti-inflammatory ergots or triptans. The patient was alternating between all of these abortive medications. The patient sought medical advice from the start and was maintained on topiramate 15 milligram per day for 5 years, and she can't recall why the dose wasn't increased more than that, and with no improvement. Attacks started to increase in frequency and severity when the patient was shifted to oxcarbazepine 1,200 milligram per day and thiopentine, an antidepressant, for 2 years with no improvement. The patient then was shifted onto pyramide 200 milligram per day, propranolol 20 milligram per day, and cinnarizine 50 milligram per day for 7 years, also with no improvement. 1 year ago, the patient received occipital nerve block with no improvement, and 4 months ago, the patient received botulinum toxin injection with partial improvement of the headache frequency and severity for only 1 month, then the same condition recurred. Current situation, the patient has near daily headache. About 3/4 of days are of migraine features, and 1/4 days of tension features, with daily use of either non-steroidals or triptans up to 8 tabs per day, and is on prophylactic treatment to pyramid 200 milligram per day, propranolol 20 milligram per day, and cinnarizine 50 milligram per day. Thank you.
Okay, well, to me this sounds like a typical case of migraine chronification, typical age group, a history of long-term significant use of medications, and it turned into a chronic daily headache with a lot of migraine features, at least 8 days per month. So we will call that chronic migraine, and there's a significant overuse of painkillers, so that's with associated medication overuse headache most likely. So I think there's a lot of debate in this domain, but in my practice, the first step would be a withdrawal of the overused medications. So there's a discussion whether you have to introduce preventive treatments immediately or you have to postpone it. At least in Europe, there's a lot of debate around this. Let's say the Danish group and so on, they will, and also in the Netherlands, they will suggest, there can be a lot of improvement simply by withdrawal. Whereas another school of thought is that you have to introduce prevention, even early on, even preventions that have been not useful in the past, because they might turn out to be useful. So that would be my first step, is to do a withdrawal. Patient has had occipital nerve block, as I understand. Oh. We often use that now. There's a controlled trial in medication overuse headache too. It may be very helpful. There's many strategies that you can use depending on what is available, and also depending on the setting. I see 4 settings. One is simple advice. Anyone can give someone simple advice. But if there's a problematic overuse, that probably won't help. But if someone is using paracetamol on a daily basis, that may work. The other way is outpatient neurology. And that's where we use, for example, well, I was going to say NSAIDs, but you can't use a drug that's been overused. And I think in the UK, naproxen is like the #1 for. We also use steroids, oral steroids. We also use sometimes, rarely, neuroleptics. And then you have inpatient neurology, where we use, for example, IV dihydroergotamine, and there's many things you can use. And then there's the 4th layer is psychiatry, when people overuse barbiturates and so on. So the setting has to be decided, and also has to fit into this patient's way of life. She's a mom with 4 kids, or she has many children. So it will be difficult.
Four offsprings.
Yeah, so it will be difficult to admit her. So you will have to work your way around that. And then you have to introduce a preventive treatment. And if I may comment on the treatments, as you say, topiramate for 5 years at 50 milligrams, that was a too low dose. Oxcarbazepine is for trigeminal neuralgia. It's not helpful in migraine. And now she's using a dose of 200 milligrams of topiramate, which is a high dose. Sometimes it's used in medication overuse headache. Propranolol is a very low dose, 20 milligrams. I mean, for example, the European Federation suggests between 80 and even 240 milligrams. Often we go to 160. And I like more and more, for example, candesartan as a migraine preventive drug. So if this patient, but it will also depend on the blood pressure, if she can tolerate this. I'll just hand over.
Yeah, thank you, Koen. I totally agree, really. The first step is to get rid of the medications, the analgesics overused. Being on topiramate for that length of time and not having much of benefit, especially in a young fertile woman, you would really really worry about her getting pregnant and having a baby having cleft lip or cleft palate. As you know, the risk usually, a baseline risk is 1 in 1,000, and if you go on 100 milligrams topiramate, that goes to 2 in 1,000. And if you go to 200 milligrams and above, you talk about 12 in 1,000 live births. It's quite a significant issue to deal with, and I agree. Probably topiramate not going to be my first line. Just it's not a clean drug. Maybe candesartan if the blood pressure is well controlled, or it's a normal blood pressure. Nowadays, the practice is just go more and more towards candesartan. It's better profile in terms of side effects.
I believe you excluded all the secondary causes in such women, except the medication overuse. And then, you know, what would I do? Just, I agree with them, except Danish group and some people in the US. They keep continuing getting the medications for analgesics, but it's better to stop all analgesic immediately. Then during that time, during the first week or during the first 10 days, helping with the, if there is a trigger points in the pericranial muscles, paravertebrals, or gone or lone area, it's better to block them twice a week, or just phenolphthalein ganglionic blockade, depending on the patient's, examination results. And then how would I go with the, drug choices? The oxcarbazepine is used as drug, and you said one of the antidepressants. I don't know whether the dosage was in the antidepressant dosage or very small dosage. I did not know that drug. You said Tibenton, but I don't know what is in. And the topiramate, if you don't get too much change, the 200 milligram is again useless. You can go back to the 100. It's okay. And propranolol, 20 milligram is nothing. We need to reach the, proper dosages if there is no side effect. If there's a side effect, we need to switch to another one. And I think there is no use of using cinnarizine as well. So, simple drugs in an effective dose and immediately correct sleep. Maybe amitriptyline would be helpful for the first few weeks. And I would start duloxetine probably, duloxetine as an SNRI, which is going to, probably that woman is having a, chronic depression, anxiety, probably topiramate has also helped us. So, with the pain threshold is going to change with if there is no problem with the blood pressure and other systemic problems, duloxetine would be nice. And even the lowest dosage of propranolol would be helpful to avoid the noradrenergic crisis, which we can see within the few weeks after starting an SNRI. And then, there is a huge need to change the lifestyle. I don't know anything about the lifestyle of that woman, but probably it's not.
She's not activity. She is a housewife, caring for her children, no exercise, diets, mainly fast foods. Yeah.
And with the diary, she has to be kept on the, close follow-up. at least for the 2 or 3 months. After a month, you can start giving the acute medications, but she's allowed to use, antiemetics.
Excuse me?
She's allowed to use antiemetics
Yeah.
as a, abortive medication.
Yeah, yeah. Oh. Okay.
Just two more comments. As you allude to, of course, in chronic migraine, we will look at all known risk factors. Medication overuse being one of them, mood disorders, other pain conditions, etc., caffeine overuse. So that's all, it's very important in chronic migraine, but it's not all about the drugs. And I think when it comes to sort of evidence-based medicine, at this moment, I think there's only reasonable data for botulinum toxin and topiramate, but I agree that we all use different things because we have to. We have made a guideline in Belgium for chronic migraine for our country, and valproate is in there as well because there's a controlled trial. But I must admit that over the years now, valproate is really increasingly unpopular. And there's been a recent publication just last week or so by the European Medicines Agency together with the European Headache Federation saying that valproate really should be the last resort in migraine treatment. And I fully agree. I didn't pay enough attention. This is a lady that's not using contraception. I mean, that's certainly an absolute no. And lastly, she has had Botox. Did I understand it correctly? She had it once? Or
Yeah.
Once,
yeah.
just once.
So then again, our practice is to do it at least twice and with a 3-month interval to mimic the preempt study design. And also it's important to use the protocol that was used in the preempt studies, because also in Belgium people say, I've used Botox, but it's a little bit at the front, whereas we should use the at least 155 dose
155
regimen with the 3-month interval. So that, because there's few evidence-based options, but I really wonder how expensive it is in
It's
Israel.
very expensive and not
Egypt.
available now.
Because in our country it's 720 euros for the two, and let's say a cleaning lady would make 1,500 euros a month. So it's not accessible for most patients. And as she is a busy housewife, I guess cost will be an issue unless it's reimbursed here.
No, even it is not available now in Egypt.
Just commenting on the valproate, now in the UK, we are not allowed to discharge patients, females on valproate in a childbearing age. They have to be seen at least once a year, even if everything is well controlled.
Okay, regarding the lines of treatment patient received, actually most of them she presented to us with this a lot of medications. Patients sometimes resist to increasing the dose because of the side effects and because of they read the pamphlet of the drugs, and this causes this is an anti-epileptic drug, this is so we also the limitations of medications, availability of certain medications and the cost, so be a problematic, and many patients expectations are very high, although they present in a very bad situation to us. Okay, so this case especially is represents the real situation happens in many clinics. Okay.
So just one comment on their expectation. It's real. I mean, probably during the social media and all the people are access to all the media news. They think if they go to the headache specialist, specialist has a something very magical, stick, and everything goes away. It's not like that. They have to work hard. They have to change their lifestyle. They have to change a lot of things.
Yeah, I sometimes tell the patient
that's the really worst expectation. First, we start talking about this. We're just going to show you the way. You're going to work hard.
Yeah, sometimes I tell the patients 50% on you and 50% on me. We are taking decisions with each other, and not only on me. And I will find the solution. Yeah.
If it's the chronic migraine patients, it's the, one of the real problems.
Yeah. Any questions?
Perhaps the panel can share with us, when you see a new patient for chronic migraine, how much time do you spend with that patient? And perhaps we can ask our Egyptian colleagues here, when they see a new patient with chronic migraine, how long do they spend with that patient?
So I've just finished my fellowship with Prof. Peter Goatsby in London, and this is very unrealistic really to get it into practice. I used to get an hour for the patient. Now in my clinical practice, where I work as a consultant neurologist, because I run a specialist headache clinic, in the UK we have a guideline come from the Association of British Neurologists. It sets the timing for the consultation. By law, a new appointment for a new neurology patient, they should get at least 30 minutes. So now there's always a take and give with the management side of the department. They always want to try, oh, you are experienced, you can see them in 20 minutes. I tend to say no, I can't do this, because legally, if things go wrong, you've agreed to see them in 20 minutes and didn't give them the right time. So as a minimum, it's 30 minutes in the UK to see a new patient's headache or not headache, any neurology complaint. If you run a specialist clinic, I used to do it in 40 minutes, so 40 minutes for a new patient.
We have 45 minutes for a new patient and 30 minutes for a follow-up, but I'm at an academic institution. I'm not a private employed physician, so I mean, my colleagues in neurology, private hospitals, they will only take at the most half an hour. But again, seeing tertiary referrals, 45 minutes often is not enough, and I end up taking an hour.
Yeah, exactly, you end up overrunning, the clinic overruns later.
So I'm running the headache part, the algology unit, and we are seeing outpatient headache clinics twice a week. We are always seeing the referred patients, so all of them are really difficult cases, and all of them, at least such a patient takes an hour. So we are filling all those files, asking all those risk factors, how many teas she's having, how many coffees, it's such details, every drug and lifestyle. Then we send her to the blood tests, and if it is necessary, we usually do the blocks and sphenopolitic ganglionic blockage, which is going to take 20 minutes to another room. So, then talk about the relatives at the same time. It's not easy, at least an hour.
In our clinic, actually, the general hospital clinic is totally different from private clinic. In general hospital, our weekly clinic, we receive ranging from 15 to 30 patients coming to us. And in my presentation in the first day of the conference, that most of patients, 50% or more, are self-referral. So I start from the beginning, but with the overcrowding in the clinic, times maximum 15 minutes. Because of patients are poor, then even fighting happens. But in the private clinic, we can put our rules. So we take from 30 to 45 in patients who need examination, detailed examination. Okay.
Thank you. Quite interesting. I don't think I will be able to manage in 15 minutes to see a patient properly.
It's a very overcrowded clinic, and we have a little resources and little personnel to attend the clinic. Young neurologists not motivated to attend more than clinic. We cannot do this, but we try. Sometimes cases we take a brief history. Clinical, sometimes the features we pick out, yes, this migraine, typical, so we prescribe medication, and then we continue sometimes in the case with the next visit, any details in the detailed sheet. Yeah, sometimes.
In an academic center.
Mm-hmm. Yeah.
In an academic center, this is where you hope that you would be able to spend more.
Yeah, we Yeah,
But you can't, I understand.
Yeah, but our plan to increase the days, but because of the limitation of personnel, we cannot take more than 1 clinic per week. So all patients, we started the clinic 6 years ago with 1 patient every 3 clinics. So we stay with him a lot of time, but now overcrowded. So we try to do our best, and more than personnel, me and Muhammad Assam and Abdurrahman, in the clinic, sometimes we have time to for patients more recently. Okay, any further questions? Okay, we can move to the next case.
Case number 3. Mrs. N.I., 39 years old, female patient, married with 2 offspring, employee in a company, lives in Cairo, no special habits of medical importance, regular menses, not on contraception. Family history, she has a positive family history of migraine in her older brother. He is on daily analgesic intake, not on any prophylactic treatment. Past history, the patient has past history of pulmonary sarcoidosis. She was diagnosed 6 years ago after a lung biopsy, and she received oral steroids for 3 years and other unrecalled immunosuppressive drugs for 3 months. Regarding the headache history, the condition started 25 years ago by attacks of headache of migraine features. It was unilateral, throbbing, associated with nausea sometimes, and increased by activity and disabling. The attacks were moderate in intensity with a frequency of 1 to 2 attacks per month. Each attack lasted about 1 to 2 days, and it was aborted by about 3 to 4 types of non-steroidal anti-inflammatory drugs during the attack. The patient didn't seek medical advice at the start, and she wasn't on any prophylactic treatment. 6 years ago, the headache markedly increased in frequency, sometimes in a temporal relation to the diagnosis of the pulmonary sarcoidosis. It became daily headache with increased severity of headache intensity and of associated symptoms, e.g. nausea, vomiting, photophobia, and phonophobia. The patient sought neurologist advice, MRI as an T1 image with contrast.